Hello everyone, this is Lilian Velasco and my presentation is Multiple Sclerosis, an evidence-informed approach for physical therapists. The primary goal of this lecture is to update physical therapy clinicians and students about current evidence-based approaches for individuals with multiple sclerosis. The objectives are, firstly, define and identify types of multiple sclerosis in current research. Secondly, discuss the prevalence of multiple sclerosis to establish the need for physical therapy. Thirdly, discuss physical therapy approaches in managing the impairments and activity limitations in patients with multiple sclerosis. Lastly, identify and discuss considerations to undertake in managing patients with multiple sclerosis. Multiple sclerosis is defined as an immune-mediated disease that involves inflammatory demyelination of axons within the central nervous system, with neurodegenerative processes resulting in loss of axons and neurons. There are about 300,000 people affected with multiple sclerosis in the United States and 2.3 million worldwide. It is highest among women, people aged 40 to 59 years, and non-Hispanics. There is a need to promote importance in participating in physical activity. Despite all the listed benefits, less than 20% of people with multiple sclerosis in the United States participate in recommended amounts of moderate to vigorous physical activity compared to healthy control population. There are changes made in 2013 revision from the 1996 clinical course description. The changes are as follows. Progressive relapsing is removed. Patients under this subtype are considered primary progressive multiple sclerosis. Clinically isolated syndrome is added and is the first clinical presentation that shows characteristics of inflammatory demyelination that could be multiple sclerosis but has yet to fulfill criteria of dissemination in time. Radiologically isolated syndrome is not a subtype due to lack of clinical symptoms. However, patients who have incidental findings should be followed prospectively. The terms benign and malignant should be used with caution. Rather, use the terms active, worsening, and confirmed. Worsening is a preferable term to describe that the disease is advancing due to frequent relapses and/or incomplete relapse recovery. Confirmed is the preferable term used when metrics such as expanded disability status scale is used. The following are current physical therapy approaches according to disability. Resistance training has positive benefits in patients with multiple sclerosis, demonstrating mild to severe disability. It can be performed with free weights, weight machines, resistance bands, or body weight. Advantages of this type of training are variation in exercise prescription and adaptability to patients, as this can also be done in seated position. Progressive resistance training can improve muscle strength, muscle power, and explosive muscle strength. Progressive resistance training is reported to be well tolerated with dropouts less than 20% and adherence of more than 90%. For aerobic training, it has strong evidence in improving physical capacity in patients with mild to moderate disability. Parameters used are moderate intensity of 60 to 80% maximum work rate or 60% VO2 max for 30 to 60 minutes for 2 to 3 times a week in a 14 to 15 week duration. For patients with a severe disability, there is no definite conclusion. However, evidence reports that there is a low dropout rates, few adverse events, and high exercise compliance in patients with severe disability. Extra gaming consists of video games such as Wii Sports or Resort Fit games, which incorporate some kind of physical exercise. It has a reported beneficial effects in balance, gait, and dual tasking in patients with mild disability. Body weight support treadmill training is a task-specific modality for walking and gait rehabilitation. It is safe for all disability levels because of use of harness. It has shown improvements on disability scores, muscular strength, several mobility tests, fatigue, independence in daily activities, and quality of life. The primary disadvantages of this type of training are the high cost and low availability of equipment. The total body recumbent stepper training is a full body training stimulus involving upper and lower extremities. It has a simple setup that can be used for community or home setting with all work done by the exerciser. Unfortunately, its efficacy is unknown as only one study has examined it. Meanwhile, electrical stimulation-assisted cycling is a combination of electrical stimulation and volitional exercise, with the electrical current stimulating greater recruitment and activation of weakened muscles. The findings have been mixed due to low quality of studies. The primary disadvantage of this is that electrical stimulation excites both motor and sensory nerves, which may cause pain for some patients with impaired sensation. One interesting study discussed about importance of frequency of physical therapy intervention. Davis and others found that the high-frequency physical therapy protocol, consisting of 60 minutes twice daily for 5 times a week in 6-week duration, improves the balance and mobility of patients with multiple sclerosis with expanded disability status scale score between 3.0 and 6.5. However, this finding should be further explored due to the study's small sample size. The current physical therapy approaches for primary progressive subtype are: firstly, multiple disciplinary rehabilitation program is reported to be beneficial in improving depression, social experience, quality of life, and fatigue, with improvements maintained 6 weeks after intervention despite unchanged score in expanded disability status scale. Secondly, the use of inspiratory muscle trainer has shown improvement in maximal inspiratory pressure and maximal expiratory pressure compared to deep breathing exercises. However, only one study has found using this technique. For pain management, use of high-frequency transcutaneous electrical stimulation, self-administered for 45 minutes twice daily for 6 weeks, may be utilized. Another alternative, albeit costly, is body weight-supported treadmill or robot-assisted gait training. Both have shown longitudinal improvements in pain. Some of the considerations to undertake in managing patients with multiple sclerosis are: firstly, signs and symptoms of multiple sclerosis are widely variable, encompassing cognition, motor, gait, sensory, visual, and bladder-bowel dysfunction. Thus, treatment plans should be individualized with patients actively participating. Secondly, cooling therapy, such as use of cold vests with active cooling, with temperature of 7 degrees Celsius for 60 minutes, or performing cooling bath before training with temperature of 16 degrees Celsius for 30 minutes involving lower body regions, can be integrated in rehabilitation to decrease fatigue during training sessions. Lastly, training intensity should be individually adapted and should be started at a low to moderate intensity level with regular rest periods to minimize motor fatigability. The next 2 slides are the references used for this presentation. Thank you for listening.